Hello everyone, my name is Dr. Fontela and I will be discussing a case of subarachnoid hemorrhage triggered by Varicella-Zoster virus vasculopathy. So background about the VZV vasculopathy, it essentially can affect both children and adults. And initially it was thought to only present with ischemic large vessel strokes. However, it's now understood that it can involve small arteries in addition to large arteries. There's a bit of a wide spectrum as well as the stroke association with the VZV infection, including aneurysm, subarachnoid, and intracerebral hemorrhage, as well as arterial dissection. So getting into the case, we have a mid-50s male, past medical history of end-stage renal disease, failed renal transplant, and with a recent diagnosis of shingles a few days prior to admission, who presented with worsening mentation and facial numbness. Due to the high suspicion for a stroke, patient was made a stroke alert, and CT brain, CTA, head and neck were all ordered. However, did not demonstrate any evidence of acute ischemic pathology or LVO or hemorrhagic pathology. 2 days after admission, the patient developed worsening mental status and worsening neurological deficits. Therefore, all brain imaging was repeated, and CT brain now demonstrated subarachnoid blood products in the right parietal region that was not previously seen on imaging. So if you refer to figure 1, they describe a subarachnoid hyperintensity in the right parietal lobe, likely representing the blood products that was mentioned. As was stated before, patient had obvious signs of a shingles infection with his herpetic lesions in the LT3 dermatomes. However, subsequent CSF analysis was performed and demonstrated the positive VZV antibodies, therefore confirming our diagnosis. The patient was then treated with acyclovir for 14 days and a short course of steroids for 5 days with notable improvement of his mental status. So as in this case, VZV vasculopathy should be suspected in a patient with a recent history of herpes zoster or varicella presenting with stroke-like symptoms or altered mental status. Diagnostic criteria can include brain imaging consistent with an ischemic or hemorrhagic lesion, as well as the testing for anti-VZV IgG antibody in the CSF, as we did in this case. In the patients with a confirmed diagnosis of the Varicella-Zoster virus infection vasculopathy, recommended treatment is with IV acyclovir for 14 days, with extension of the duration of the treatment with patients who have not provided any clinical improvement. In addition, a short course of oral prednisone is also recommended to minimize inflammatory response from the arteries that are infected with the virus. Additionally, there have been a few reported cases where patients treated with both acyclovir and steroids have better outcomes compared to those who were treated with the acyclovir alone. Overall, prompt treatment is important for improved clinical outcomes in addition to close monitoring to assess improvement of any neurological deficits and to assure that no new strokes have occurred throughout the clinical course. That is my case. Thank you for your time.